Hello everyone. Once again, I welcome everybody to this live session. And in the very onset, I would just like to say sorry because we were having some technical issues, and for that, we could not go on live on time. So, once again, very sorry. We kept you waiting, but I hope now you will enjoy the class. I hope there is no more technical issues so that we can continue smoothly like other days. So let's begin with today's topic, that is STEMI. Okay, ST segment elevated myocardial infarction. This is probably the most important and most dreadful of the acute coronary syndrome. And it is, of course, a medical emergency. It is of abrupt onset. And if you don't treat on time, the patient is going to lose their lives. So it is something, if we know the management of STEMI, we know how to save many lives. So let's begin. As I have already talked about ischemic heart disease, it includes stable angina, which I have already discussed. It includes acute coronary syndrome. Acute coronary syndrome, acute means it is abrupt in onset, okay? And because of abrupt reduction in the coronary flow, the patient can present in two ways, either of the ways, like first is patient can present with acute ST elevated myocardial infarction, and the patient may present with unstable angina or NSTEMI. I have already discussed about unstable angina and NSTEMI in my previous lecture. So today's topic, let's begin with it, that is acute ST elevated myocardial infarction. This slide also I have shown previously also, just to have a brief revision about the slide. Okay, when the stable plaque is fixed and stable, we have stable angina. This is the plaque. Okay, plaque initially begins in the walls of the coronary arteries and then it encroaches the lumen of the coronary. So once it is stable and fixed, we get stable angina, and once there is disruption of the plaque. Because of disruption, there will be aggregation of platelets, which results in unstable angina, unstable plaque. And if there is activation of the coagulation cascade, there will be formation of thrombus. So if the thrombus is there, but it is not occluding whole of the lumen, then the patient will have non-ST segment elevated myocardial infarction. And if it occludes whole of the lumen, see thrombus is occluding the whole of the lumen of the coronary, then the patient will have ST segment elevated myocardial infarction. That's why I said it is probably the most deadliest of the spectrum of ischemic heart disease, and we really need to know how to manage it. So, if we talk about the definition of myocardial infarction, this is also known as the universal definition of myocardial infarction. We keep on talking about MI, but definitely there is a bookish or theoretical definition. So, what is the definition? Acute myocardial infarction should be used, the term acute AMI, okay, AMI, acute myocardial infarction should be used when the following criteria are fulfilled. So what are the following criteria? Okay, first of all, there should be a rise in the cardiac biomarkers. I have already discussed about cardiac biomarkers. That is, most commonly we go for cardiac troponins. So there will be rise in troponin. Okay, we need to do serial measurement of troponin. So there will be rise, at least one value of troponin will be above the 99th percentile of the upper limit, upper reference range, with at least one of the following. That means the raise in the cardiac biomarker is constant, it should be there, plus one of the following things should be there to term it or to label the patient as acute myocardial infarction. So what are those? Symptoms of ischemia. We know what are the symptoms. There will be constricting or squeezing type of chest pain. The patient will have radiation of the chest pain in different areas like in the neck, jaw, or in the forearm, ulnar aspect of the forearm. Okay, there will be diaphoresis. There will be anxiety, paleness, full camiscline. Okay, next, there will be ST segment changes, STT segment changes. Okay, it should be new. It should not be old, definitely. It should be new STT changes, okay? Or there should be development of new left bundle branch block. So mind it, even if there is no ST segment elevation, there is only new onset left bundle branch block, then also you should consider it as ST segment elevated myocardial infarction. Development of pathological Q wave in the ECG. What is pathological Q wave? I am going to come to this later on. Okay. And imaging evidence which shows regional wall motion abnormality. So this word is important. Wall motion abnormality. Okay. In echocardiography, we will be able to see what is known as RWMA, means regional wall motion abnormality. Okay. And lastly, angiography will show us the thrombus, coronary thrombus. So any of the five features, okay, that is symptoms of ischemia, ECG changes like new STT changes or development of new onset left bundle branch block, or else if there is development of pathological Q wave, or else on echocardiogram if there is regional wall motion abnormality, okay, or else by coronary angio if there is presence of thrombus. So if any one of them are present along with the raised cardiac biomarker, that is cardiac troponin, then we should call the case as acute myocardial infarction. So this is the universal definition of acute myocardial infarction, which we should definitely be knowing. Coming to the classification of myocardial infarction, okay, myocardial infarction also has a classification. There are different subtypes of myocardial infarction. It is divided into 5 types, 1, 2, 3, 4, and 5. 4 is again divided into type 4A and 4B. So let us see what are the types. Okay, these are very important because if we know the types or subtypes, we will not miss the case of myocardial infarction. First, there is spontaneous myocardial infarction. Okay. Type 2, myocardial infarction due to an ischemic imbalance. What do you mean by ischemic imbalance? Ischemic imbalance means when there is increased myocardial demand, but the blood supply is not adequate, then the patient develops myocardial infarction. Okay. So that is type 2, secondary to an ischemic imbalance. Type 3, myocardial infarction, which is resulting in death, but we do not have the biomarker values. I'm sorry, the screen is again gone. I'll take 1 minute break and I'll try to reconnect it. So, welcome back. So, type 3, that is myocardial infarction, which results in death. Okay, but unfortunately, those cases where we do not have a cardiac biomarker, so we have to rely on other measures or we have to rely on autopsy finding to say that the patient had myocardial infarction. Okay, so type 3 is myocardial infarction resulting in death when biomarker values are not available. Okay, coming to type 4, type 4A, that is myocardial infarction related to PCI. PCI, we all know this is percutaneous coronary intervention. Okay, so after PCI, if there is myocardial infarction. It is type 4A. 4B, myocardial infarction related to stent thrombosis. Okay, so these are post-procedural myocardial infarction. The procedure has been done, and because of certain complication, if the patient again develops myocardial infarction, these are type 4A. Type 5, when patient develops myocardial infarction related to CABG, coronary artery bypass graft. So, just to mention that we need to remember when we say type 4 and type 5. Type 4 and type 5, as I said, they are related with the procedures done. That is PCI, coronary stenting, and CABG, coronary artery bypass graft. So, if it occurs within 48 hours of the procedure, and for type A, the cardiac troponin should be raised by more than 5 times of the upper limit. Okay, 5 times. And for type 5, again, myocardial infarction should occur within 48 hours of CABG. And in this case, the cardiac troponin should be raised by 10 times of the upper limit. This is, we're talking about troponin. Okay, cardiac troponin. So these are very important from your competitive exam point of view. Like when you say it is CABG related myocardial infarction, when you say it is PCI related myocardial infarction, and it is very important from your practical point of view as well. So this was the classification of myocardial infarction. Okay. Coming to the clinical features is almost similar like stable angina or STEMI unstable angina we have discussed. But importantly, in this, the patient usually has a history of precipitating factors. Precipitating factors like vigorous physical exercise, okay, emotional stress, or some medical or surgical illness. These are also very stressful conditions. Even in hospitalized patients, those who are admitted for some other medical condition or admitted for surgical illness, okay, for surgery, someone is admitted to ward, sometimes we found that they develop myocardial infarction, STEMI. So these are certain precipitating factors which we should be remembering, and we should be asking from the history as well. And we need to remember that it usually happens during the morning hours, few hours after awakening, and it may also happen after having a heavy meal on a cold, clammy day. After having a heavy meal, okay, this myocardial infarction may happen. The idea behind that is if someone is susceptible to develop myocardial infarction, we should try to reduce the cardiac workload in the morning hours, okay, and after meals. Coming to the symptoms. So what are the symptoms? The patient will have chest pain, that will be retrosternal, okay, just beneath the sternum, substernal. It will be deep visceral pain. Again, it will be like something like squeezing, or the patient will typically say like, I feel that some heavy, very heavy object is kept over my chest, like that, okay. It will be like heavy squeezing, crushing type of chest pain, and it may radiate, okay, to the upper back. It may radiate bilaterally in the forearm, okay. It may radiate up to the jaw, neck, jaw, okay. But just remember that it never radiates into the trapezius muscle, okay. If it radiates into the trapezius muscle, if chest pain radiates to the trapezius muscle, you should think otherwise, and you should think of acute pericarditis, okay. So in case of acute pericarditis, the pain refers to the trapezius muscle, but never in case of myocardial infarction pain. Along with the pain, the patient will have certain sympathetic symptoms, like the patient will have nausea, vomiting, patient will have anxiety, there'll be increased sweating, which is also known as diaphoresis, okay, diaphoresis. So patient will have diaphoresis. Patient will have, definitely patient will complain of fatigue, weakness, this thing, and there'll be sense of impending doom. Because of anxiety, the patient will have a sense of impending doom. So it is like a medical emergency. From the uh, symptoms itself, we know it. হ্যালো, আসছে পরিবার। So, just need to remember that in case of anterior wall infarction, there will be sympathetic nervous system overactivity, and just the opposite happens in case of inferior wall myocardial infarction. If there is inferior wall myocardial infarction, there will be parasympathetic hyperactivity leading to bradycardia and or hypotension. Okay, so this is again important from the clinical point of view, what kind of finding we may get, okay, depending on the walls involved. Other than those, on examination of the cardiovascular system, what signs you may get? The precordium usually remains quiet and it will be difficult to palpate the apical impulse. Okay, it will be difficult to find out the cardiac effects. There may be presence of S3 or S4. If the patient develops cardiac failure, then there will be presence of S3 or S4. There is usually decreased intensity. Hello? 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 হ্যালো, হয়েছে তো, আসছে তো। হ্যালো, তো ভালো আসছে। হ্যালো, এই দেখো। হ্যালো, 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 1 2 3 4। হ্যালো, 1 2 3 4। Hello, 1, 2, 3, 4. Hello, hello, hello. Transition. So there will be transient mid-systolic or late systolic apical murmur. Why there is mid-systolic or late systolic apical murmur you may get? It is because of mitral regurgitation. If there is involvement of the papillary muscle because of myocardial infarction, there will be rupture of the papillary muscles. Okay, the papillary muscles will get ruptured. Okay, ruptured papillary muscle will result in mitral regurgitation, and because of mitral regurgitation you will get a mid-systolic or late systolic murmur, okay, in the apical region. There may be pericardial friction rub. If there is development of pericardial effusion, there will be pericardial friction rub. Okay, so these are the signs which you may get on physical examination of the patient, on the examination of cardiovascular system. Coming to the investigations, what are the investigation we do? Initially, we do an ECG, then we do cardiac biomarkers, and then we do cardiac imaging. Okay. So just to tell you, ECG is one of the very important diagnostic tool, okay, for this myocardial infarction. So we need to take a simple 12 lead ECG. As soon as we see the patient, okay, we should be taking an ECG after the patient presents with chest pain and all the typical symptoms. And when we are going to call it as changes of STEMI in the ECG. So what are the changes which are consistent with ST segment elevated myocardial infarction? That means how much ST segment elevation should be there. So there are criteria when you call it as STEMI. If in the ECG there is elevation of the J point by more than or equal to 2 millimeter in lead V2 and V3, okay, and more than or equal to 1 mm in all the other leads. This is true for male persons more than 40 years. Okay, male more than 40 years. You will have J point elevation which is 2 mm or more in lead V2 and V3, and in the other lead if it is more than 1 mm. What is J point, by the way? Suppose this is an ECG. Okay. This will be P wave, Q, R, S complex. This will be T wave. Now what is the J point? J point is where the S wave ends and ST segment starts. So this will be the J point. Okay. This point will be the J point. J point. Where the QRS ends and the ST segment starts. So that is the J point. So there will be elevation of J point. As I say, the criteria for male more than 40 years. In case of male less than 40 years, the elevation in lead V2 and V3 should be 2.5 or more, and in other leads it is more than 1 mm. And lastly, for female, okay, it should be more than 1.5 or equal to 1.5 in lead V2 and V3, and 1 or 1 mm in all other leads. So it is very clear from here, because many times we get confused by seeing the ECG, like whether we need to say it as STEMI or it is not a ST segment elevation which is fulfilling the criteria. So this is the definite criteria when you should say that okay, this patient is having ST segment elevated myocardial infarction. Other than this STT changes, there will be new onset LBBB. As I said, new onset left bundle branch block. So what is left bundle branch block? I will not go into the detail, but I will just give you an idea how to see that if there is left bundle branch block in the ECG. You need to look at lead V1, okay, and you need to look at V6, okay. In lead V1, the QRS complex will look like this, okay, and in lead V6 the QRS complex will look like this. So it is almost like a W and it is almost like an M, okay. So this is how you can identify if there is any left bundle branch block pattern. In V1, the QRS complex will look like W, and in V6 it will look like an M, plus there should be left axis deviation. So if these criteria are fulfilled, okay, either of these criteria is fulfilled, plus there is left axis deviation of the QRS complex, then you call it as LBBB. Okay. Now, if it is a new onset or old onset, that you need to have old ECG of the patient and you need to compare probably. Okay. ST elevation in right precordial lead, it will give you an idea of right ventricular myocardial infarction. If you're suspecting right ventricular myocardial infarction, you need to place the ECG lead on the right side of the precordium, or right side of the chest, and then you take the right sided leads. Most sensitive is V4R, V4 on the right side, which will give you an idea about right ventricular myocardial infarction. When we suspect RVMI, if the patient has inferior wall myocardial infarction, okay, then we need to rule out along with the inferior wall whether there is involvement of right ventricle or not. Why so? Because they share the same blood supply. Okay, the blood supply is from the right coronary artery. So because right coronary supplies the inferior wall as well as the right ventricle, so we need to think whether they are happening together or not. Okay. And for posterior MI, we need to see if there is ST segment depression in precordial leads. Okay, that is V1 and V2. For posterior wall of the left ventricle, we do not have any leads which we place in the posterior wall. So we need to rely on the leads which we place in the front. Okay, so we need to rely on V1 and V2. Okay, I will just give you the idea in brief how to find out if there is posterior wall MI from ECG. Okay, suppose in lead V1 you are getting an image like this. This is the tall R, okay, and there is ST depression, okay, and suppose this is an upright T. This picture you are getting in V1, okay, tall R, depressed ST and upright T. So what will be the mirror image of it? The mirror image of it will be like this. So this is the mirror image. And how does it look like? It looks like a pathological Q wave, and this is the elevation of ST segment, and this is the depression, inversion of the T wave. So this is a typical picture of a fully evolved myocardial infarction. So V1, where the V1 is placed, okay, just posteriorly, diagonal to it is the posterior wall. So if in V1 we get a picture like this, we can think that what is happening in the posterior wall, this is happening in the posterior wall. If we could probably place a lead on the posterior wall, we would be seeing like this. So in this way you can identify if there is posterior wall infarction or not. This is from the ECG. It is quite interesting, so I felt like sharing with you. Now pathological Q waves also, if there is development of pathological Q wave, you know that there is a chance of myocardial infarction. What is pathological Q wave? When the duration of Q, that is more than 1 small square, okay, depth of the Q more than 1 mm, okay, or the depth is more than 25% of the QRS complex. Okay. These are the criteria for saying it as pathological Q wave. So from the ECG, you will get ST segment elevation or the J point elevation, as I have said the criteria. You will get new onset LBBB, okay. In case of posterior wall, you will get the picture as I have drawn in V1, okay. In case of RVMI, you will have to place the lead on the right side of the chest and you will get a picture of fully evolved MI, or you may get only pathological Q wave also, okay. So these are the criteria of pathological Q wave, right? Now the most important part We have diagnosed a case of ST segment elevated MI from the ECG, and cardiac biomarkers definitely it will be raised, as I have already said, and on cardiac imaging there will be regional wall motion abnormality, that also I have said. So now we have encountered a patient who has presented with the typical symptoms. We did an ECG, we found all the changes suggestive of myocardial infarction, okay, and then we found all the changes in the coronary angio, if we are able to do coronary angio, and then we diagnosed a case, and now our job is, okay. Again, there is some technical issues. I will take 1 minute. So pre-hospital care, okay, how we are going to do pre-hospital care. It is very important to do take care of the patient before even the patient reaches the hospital, because it is found that almost half and sometimes more than half of the patients, they do die even before reaching the hospital when they have an attack of myocardial infarction, okay. So the major elements of pre-hospital care include recognition of symptom by the patient. Definitely patient should be should be knowing the symptoms, okay, when should suspect a cardiac emergency. Rapid emergency team should be deployed. The patient knows the symptoms, patient will call for help, then rapid emergency team or emergency medical team will be deployed to the patient's place, and then there will be expeditious transportation to the hospital, because time is gold, okay. In this management of STEMI, time is really gold. And then there should be implementation of reperfusion therapy expeditiously and judiciously. So these are the things. Symptoms should be recognized, patient should call for help, emergency medical team should reach the patient as soon as possible, and then they should transport the patient safely, expeditiously to the hospital, where there should be expeditious implementation of reperfusion therapy. So that is about the pre-hospital care. Management in the emergency department, okay, what are the things we should be doing in the emergency, okay. General measures, I will be talking what are the general measures we should take. Control of pain, the patient will be having severe chest pain, okay, we need to control the pain, we need to control the symptom. And then rapid identification of patients who require reperfusion therapy, okay, urgent reperfusion therapy. So we need to triage the patients who will be requiring reperfusion therapy and who will be not. As I was talking about the general measures, what are the general measures we can take in the emergency department? Or if the emergency medical team has reached the patient's place, they can also administer all these things which I am going to tell. The general measures they can also administer if they are trained enough. Or if the patient directly comes to hospital, then we need to do it. So first of all, we need to give aspirin. Very, very, very important. We need to give aspirin. The loading dose is 160 to 325 milligram. Patient should chew the aspirin, and it can be followed by a daily dose of 75 to 162 milligram. We need to give oxygen, okay? Even if the patient's saturation is normal, we will give oxygen. Why so? Because we don't want to increase the cardiac workload. We want to give rest to the heart. So we will give oxygen at a rate of 2 to 4 liter per minute for at least 6 to 12 hours, okay? Then for control of cardiac pain, what are the medications we can give for controlling the cardiac pain? First of all, the first choice is nitroglycerin. We need to give sublingual nitroglycerin. We can give up to 3 doses of 0.4 mg. So remember 3 dose, remember the route, sublingual, remember the dose, 0.4 milligram every 5 minutes we can give, okay, up to 3 doses. When we should not give? If the patient is in cardiogenic shock, systolic blood pressure is less than 90 with bradycardia, and if there is clinical suspicion, okay, it should be suspicion of RV infarction. So in these cases we will not give nitrate because nitrate will cause more hypotension in the patient. And why not in RV infarction? Because the cases who has RV infarction, they are very prone to develop hypotension and cardiogenic shock. So we should not be giving nitrate to them. Otherwise, this is the drug of choice to control the ischemic pain. Now, if the patient is not responding to nitroglycerin or we have to add a second agent, we will give morphine. Okay. Other than controlling chest pain, okay, morphine has other beneficial effects as well. So we need to give morphine at a dose of 2 to 4 milligram intravenously, and if the pain is not controlled, we need to repeat the dose of morphine. We can repeat at an interval of every 5 to 15 minutes. The dose is 2 to 8 milligram. Okay. Loading is 2 to 4, maintenance is 2 to 8 milligram. Every 5 to 15 minutes we can give until the patient gets relieved, okay, of the chest pain. So it is very important. Now, beta blocker. We need to give beta blocker also as an anti-ischemic and anti-ischemic measurement. Okay, metoprolol 5 milligram to be given every 2 to 5 minutes for 3 times. Again, remember 3 times. We give metoprolol 5 milligram intravenously 3 times, and then we need to continue orally. What is the oral dose? 50 milligram every 6 hourly for 2 days, followed by 100 milligram twice daily. I am not going to discuss about the doses of all the drugs, but these are the very important drugs which you need to administer as soon as you see the patient and you diagnose the patient as having STEMI. Okay, so you really need to remember these dosing, and these are not very difficult also. You can easily remember the dosing. Okay, so beta blocker, first infusion, start infusion, IV injection of metoprolol 5 milligram. It should be followed by, after 3 doses, it should be followed by orally metoprolol 50 milligram 6 hourly for 2 days, to be followed by 100 milligram, okay, twice daily. Now that was about the general measures, what we do and what we do to control the chest pain. Now coming to the definitive therapy. Definitive therapy is the reperfusion therapy. Okay, as the name suggests, reperfusion therapy, that means we are going to try to establish the coronary blood flow again. So that is the most effective way of restoring the balance between myocardial oxygen supply and demand. Now we need to know for whom we need to do reperfusion therapy. Who are the candidates for reperfusion therapy? So how we decide? We look at the ECG, and if there is elevation of the ST segment for at least 2 mm in contiguous, 2 contiguous precordial leads, okay, and 1 mm in 2 limblets, okay, contiguous limblets. What do I mean by contiguous, okay, precordial leads? Or contiguous limb leads. This is limb leads also, contiguous limb leads. What do you mean by contiguous? Contiguous means leads representing the same wall. Okay. Just for example, let's say there is involvement of the inferior wall. So in the inferior wall, the leads, ECG leads which represents the inferior wall are lead 2, limb leads. These are limb leads, augmented leads, AVF. So lead 2, 3 and AVF. So if there is ST elevation of more than 1 mm in 2 or more of the leads, okay, then it will be a case of reperfusion, candidate for reperfusion. Okay, two contiguous leads means two leads representing the same wall. Now if there is ST elevation in lead 2 and there is ST elevation in lead 1, that does not fulfill the criteria. They are not contiguous leads. Okay, so in chest leads or precordial leads 2 mm, okay, 2 or more, and in limb leads 1 or more. Okay, but that should be contiguous. So this is the criteria by which we decide that which patient should undergo reperfusion therapy. In the reperfusion therapy, we have two options. One is fibrinolysis or thrombolysis, we can say, and the other one is invasive strategy, that is doing a PCI, okay, or doing a CABG, right? So fibrinolysis, thrombolysis, okay. For fibrinolysis or thrombolysis, how much time we can dedicate? It is very important that we maintain the door to needle time of 30 minutes. Okay, it should not cross 30 minutes. What do you mean by door to needle time? Door to needle time means once the first you see the patient, okay, and then you start doing the fibrinolysis or thrombolysis. Okay, so the period is 30 minutes. So first you see the patient, within 30 minutes you should be starting thrombolysis. That is the criteria, and that is very important. That's why I said time is gold in this case. Door to balloon. Okay, what do you mean by door to balloon time? That should be less than 90 minutes. So for percutaneous interventions, percutaneous coronary interventions, the first medical contact, okay, from the first medical contact, the time when you start doing a PCI should be less than 90 minutes. It should not cross more than 90 minutes, okay. Now, which one you should choose? You should choose PCI or you should choose, fibrinolysis. Which one you should choose? If the patient presents within 3 hours of the symptom onset, there is no preference, okay. And if the patient presents after 3 hours, then you need to think of. So, what is the protocol of doing reperfusion? We really need to maintain the protocol because we need to maintain the time, door to needle time, door to balloon time we need to maintain. So, we should go by protocol. I'm very sorry, again there is some problem. I'll come back soon. So, when you find a STEMI patient who is a candidate for reperfusion, okay, you know that this patient is having STEMI and the patient is a candidate for reperfusion. What you do? If the patient is initially seen in a PCI capable hospital, that means the hospital should have a PCI setup. In it is in our country, it is very difficult actually. In small states it's very difficult to get a PCI capable hospital, okay. The metros and big cities they do have, but again there may be the hospitals may be engaged with many patients. So if in those cases when the patient is seen in a PCI capable hospital, patient may present to a PCI capable hospital, patient may present to a non-PCI capable hospital. So if the patient presents to a non-PCI capable hospital, which happens most of the time, okay, then what we should do, okay, if the DIDO, what is DIDO? DIDO means door in, door out. Door in, door out. What does it mean? Okay. Door in, door out time should be 30 minutes or less than 30 minutes. What does it mean? Once a patient is seen in a PCI non-capable hospital, and if it is possible to shift the patient to a PCI center within 30 minutes, that is door in and door out time. If the patient can be transferred to a PCI capable hospital within 30 minutes, then patient should be transferred, and the first medical contact, FMC stands for first medical contact, okay, to device time. That means from the first medical contact to starting the procedure, the time should be less than 120 minutes, 120 minutes or less, okay. If the patient presents to a non-PCI capable hospital, and if we see that the first medical contact to device time is going to be more than 120 minutes, then we will do a thrombolysis then and there, okay. So just remember the timing. Patient has presented to a non-PCI hospital, and if we can shift the patient to a PCI hospital where the timing will be less than 120 minutes, we will immediately shift the patient. And if the hospital is far away, okay, we cannot shift the patient and start the procedure within 120 minutes, then we will do thrombolysis in the present hospital. We will do thrombolysis and then we will decide what to do with the patient, okay. After doing thrombolysis or fibrinolysis, if thrombolysis fails, then we need to urgently transfer the patient to a PCI capable hospital. And if thrombolysis is good, then we can shift the patient within 3 to 24 hours. Means if thrombolysis is good, then we have some time in our hand. Within 24 hours, we need to shift the patient to a PCI hospital. If thrombolysis is failed, then we need to transfer the patient as soon as possible to the PCI capable hospital. And as I said, if the patient is initially seen in a PCI capable hospital, okay, immediately patient should be done with the procedure, okay. The first medical contact to device time should be less than 90 minutes. I have already said. What they do in the PCI lab, cath lab, they will do a diagnostic angio. Depending on the diagnostic angio, depending on the amount of stenosis, okay, the degree of stenosis, they are going to advise medical therapy only, or maybe PCI or maybe CABG. Okay, this is how we actually do a triage and we shift the patient depending on the timings. This is the protocol actually. When do we prefer PCI? Okay, preferred when diagnosis is in doubt. First thing, fibrinolysis is contraindicated. There are many contraindications of fibrinolysis I am going to talk about next. Cardiogenic shock if present, we cannot do fibrinolysis, we need to do a PCI. Increased bleeding risk, okay, symptoms present for more than 3 hours. I have said if the patient presents within 3 hours, there is no preference, okay. But if the patient presents after 3 hours of the symptom onset, then we need to do a primary PCI. That is the protocol. If patient has congestive heart failure and Philip class is more than 3, again we need to do a PCI. If there is electrical instability, means patient has arrhythmias and hemodynamically unstable, then we need to do a PCI. So we understand all the criteria when we need to do a PCI. What is Philip's class? Okay. What is Philip's class? Philip's classification is mainly done to see the see at what stage the patient is having. Philip's classification has 4 stages. Stage 1, this is post-infarction. What happens to the patient post-infarction? Okay, so after myocardial infarction, if there is no sign of cardiac failure, no sign of congestive heart failure, this is grade 1 or stage 1. If there is signs of congestive heart failure, what are the signs of important signs of congestive heart failure? We all know there will be presence of S3, okay. There will be elevation of the jugular venous pressure, okay. There will be basilar raise, means there will be fine crepitations on
base of the lung. Okay, in the bi-basal area there will be fine crepitation, which is known as basilar rate. So these are the excuse me, these are the signs of congestive heart failure. So if the patient has these signs, it will be class 2. Okay, if patient develops pulmonary edema, it will be class 3. Class 4, it will be cardiogenic shock. So, if the patient has a class 4 Phillips classification or stage 4 Phillips classification, we cannot do a thrombolysis, we need to do PCI. That's what I have just said. Congestive heart failure, Phillips class more than 3, we need to do a PCI. Phillips class is important from your MCQs or competitive exam point of view also. So, you need to know this. Coming to the PCI, there are different namings given to the PCI. What is primary PCI? Okay, I will just go fast. What is primary PCI? Primary PCI means when you do a PCI with the first contact with the patient. Okay, means you do not do any thrombolysis. You have seen the patient and you do a PCI. That is primary PCI. Okay, without prior administration of fibrinolytic agent, and this is the gold standard for the treatment. Okay, primary PCI. What is facilitated PCI? Facilitated PCI means you have done a thrombolysis, okay, and then you will send the patient for PCI within 24 hours. That is facilitated PCI. I will go back to the slide again. In the protocol, I have said that after fibrinolysis, you can send the patient for PCI within 3 to 24 hours. So that is facilitated PCI, and this is known as rescue PCI. Okay, that means the patient thrombolysis has failed and then you're going to send the patient for PCI, that is rescue PCI, and the other one is facilitated PCI. I will go back to the slides. So this is about facilitated PCI. You need to know the namings because again it is important from your MCQ point of view. What is pharmacoinvasive therapy? Pharmacoinvasive therapy, again it is almost similar like a facilitated PCI where you do a fibrinolysis or thrombolysis and then you send the patient for a PCI. Rescue PCI, I have already said. If there is failed thrombolysis, then you do a PCI, which is known as rescue PCI, and it should be done within 90 minutes of the first medical contact. That means we need to maintain the time frame or time window. This is, I have already said, only PCI done, it is primary PCI. Pharmacoinvasive strategy means thrombolytics given and after few hours you do a PCI. Rescue PCI, when thrombolysis fails, then you go for a PCI, that is rescue PCI. Facilitated PCI, you give thrombolytics and you go for a PCI. Okay, that is facilitated PCI. What is the difference between facilitated PCI and pharmacoinvasive strategy? In facilitated PCI, the time frame is less. Okay, you send the patient very soon for PCI. In pharmacoinvasive strategy, you send the patient later on. What we do after doing PCI? After doing PCI, we do coronary stenting. Okay, that is one of the method of reperfusion. So there are different types of coronary stents. I will not go into the detail, but just know that there are drug-eluting stent these days. There are drugs, okay, which slowly is released from the stents. Why the drugs are given? So that there is prevention of smooth muscle proliferation and restenosis. Okay. Previously, they were using bare metal stent. Bare metal stent means no drug was there. Bare metal stent, which had a high incidences of restenosis. So after using drug-eluting stent, there is very less chance of restenosis because it will prevent the proliferation of the vascular wall smooth muscle. There are different generation of drug-eluting stent. I will not go into the details, but just know that first generation, the drug used were sirolimus and paclitaxel. Again, important from your MCQ point of view. Okay, sirolimus, paclitaxel, first generation or the initial stents. Second generation, they use everolimus or zoterolimus. Okay, they all are sirolimus analog. So everolimus and zoterolimus modified from sirolimus. That is the second generation drug-eluting stents. And in the third generation, what drug they use? They use biolimus, which is extremely lipophilic. Okay, so the newest, the third generation, they drug-eluting stent, they use biolimus, a sirolimus analog again. So just remember the drug's name and the generation, first, second, and third generation. Newest drug used is biolimus. Just to give you an idea about how a PCI is done, this is a catheter. Okay, this is a catheter and this is a deflated balloon. Okay, this is a deflated balloon. And here you can see in the cross section the lumen is very much compromised. This is the lumen. So lumen of the coronary artery is very much compromised because of the this atheromatous plaque. Now what they do, they actually enhance a balloon catheter, okay, balloon which is attached with the catheter over a guide wire, and they go in the area of stenosis. After that what they do, they inflate the balloon like this. Okay, it is very interesting. They inflate the balloon like this. This is the cross section. Okay. After inflation, what they do? They will remove it. Okay, they will remove the balloon and see the lumen is beautiful now. Okay, the balloon is deflated. They have removed the balloon. So this is the lumen now. Okay, in the next step, what they do? They place a stent which is mounted over a balloon. Okay, so there will be a stent and inside there will be a balloon. They will put the stent in the stenosed area. Okay, in the stenosed area they will put the stent, and now they are going to inflate the balloon. Okay, when they inflate the balloon, the stent will just push against the walls. Okay, stent will just push against the walls, and after that, once the stent is fixed to the wall of the coronary, they will deflate and remove the balloon. Okay, this is the procedure of coronary stenting. It is very interesting. I have talked all about stenting, how PCI is done and everything. Fibrinolysis, okay, as I have said, door to needle time should be within 30 minutes. What are the agents we use for fibrinolysis? Okay, TPA stands for tissue plasminogen activator. Tissue plasminogen activator. Streptokinase, it was used previously, but these days it is used very less. I will tell why. Tenecteplase and retiplase. So these are the drugs we use for fibrinolysis. What do? They will convert plasminogen to plasmin, okay, and then plasmin will cause the lysis of the clot, okay. So why streptokinase is no more used? Streptokinase, actually these are first generation or older drugs. They are not fibrin specific. Okay, but the newer generation, these retiplase, tenecteplase, they are fibrin specific. What do I mean by fibrin specific? These newer drugs, those who are fibrin specific, they will cause lysis only in the clot. Okay, they will not cause any systemic fibrin degradation. Whereas streptokinase, it causes systemic degradation of fibrin as well, resulting in increased chances of bleeding. So basically these newer generation, they are associated with less chances of bleeding comparing to the older agents. They are fibrin specific. Okay, they are fibrin specific drugs, important for MCQs. Okay. When I take the class, I will in between I will tell you the important MCQ points also like this. Okay. Retiplase. Retiplase is given as double bolus. So it is also known as a double bolus drug. Okay, it is given 10 units followed by a gap of 30 minutes, then again 10 units. Okay, this is why it is said as double bolus. 10 units, okay, 30 minutes gap, then again 10 units. Tenecteplase given as a single bolus. Okay, so which drug is given as single bolus? That is tenecteplase. So these are the drugs which are very much used these days for fibrinolysis. What are the contraindications of fibrinolysis? We really need to know this, because if these contraindications are present, we cannot do a thrombolysis. We need to go ahead with a PCI. History of intracranial hemorrhage. Okay, stroke within last 3 months. Stroke within last 1 year. Stroke within last 1 year except ischemic stroke for last 3 months. If the systolic blood pressure is more than 180 and diastolic blood pressure more than 110, we cannot do a thrombolysis because there will be high risk of bleeding again. So lower down the blood pressure, systolic blood pressure, diastolic blood pressure, and then we can do a thrombolysis. If there is suspected aortic dissection, contraindication to thrombolysis, active internal bleeding, closed head or facial trauma within last 3 months, known malignant intracranial neoplasm, okay, IC money intracranial neoplasm, and known structural cerebral vascular lesion, okay, AV malformation. So these are the contraindications for doing a fibrinolysis. Most of them are related with increased bleeding if you do a thrombolysis in these group of patients. Okay, so be very careful with that. Thrombolysis has been successful. Okay, you need to know if your thrombolysis is successful. If it is unsuccessful or if it is failed, then you need to shift immediately the patient to a PCI center. Okay, there should be resolution of chest pain, okay. ST elevation should come down by 50% of the presentation, okay. You can do an echocardiogram. There should not be any regional wall motion abnormality. So these are the criteria when you say if the thrombolysis is successful or not. Resolution of chest pain, the patient will be relieved of chest pain. The ST elevation will come down by at least 50% and there will not be any regional wall motion abnormality on coronary angio. Coming to the management in hospital, okay, we need to take care of the activity, diet, bowel and sedation, okay. In the general management activity, patient should be advised for bed rest at least for 12 hours. Okay, why so? Because if the patient is up and above, the patient is moving around, then there will be increased cardiac workload, which will increase the size of infarction. So we should limit patient's activity. Bed rest for 12 hours, which should be followed by, if there is no complication, it should be followed by an advice of sitting up with dangling the feet on the side of the bed, on the edge of the bed, or the patient can sit up. And sit in a chair. This will help psychologically also, and there will be decrease in pulmonary capillary pressure, wedge pressure. Then slowly the patient can be ambulated. Regarding diet, initially for at least 12 hours, we need to give clear fluid only. Why so? Because there always remain chance of aspiration and vomiting. Okay, so we need not give any food for first 4 to 12 hours. We need to give clear liquid, which can be followed by a semi-solid diet. Okay, and we need to restrict consumption of fat. Bowel habit, we don't want any constipation in this group of patients, because if there is constipation, patient has to strain, there will be increase in myocardial workload, increased size of infarction. So these small things also very important. We need to really take care of these things. So we need to use stool softener, and if needed we can use laxatives also to make the stool soft. The patient should not strain. Sedation, yes, sometimes it is very much required because we are enforcing the patient for bed rest. So sometimes sedation is also required. So we can use drugs like diazepam, lorazepam or oxazepam. These are benzodiazepine group of drugs. So these drugs are recommended for using as a sedative in these cases. Pharmacotherapy, among the thrombotic agents. In the antiplatelets, we will be giving aspirin loading dose, clopidogrel loading dose, followed by a combination of aspirin and clopidogrel every day for at least 12 months. Okay. And then we need to decide, depending on the case, whether we are going to continue dual antiplatelet therapy or we need to give aspirin for lifelong. That will vary from patient to patient. As an anticoagulant, we can use unfractionated heparin, okay, which is not much preferred because unfractionated heparin requires monitoring of APTT. APTT should be within 1.5 to 2 times of the control. Low molecular weight heparin is preferred because it usually does not require any monitoring. Okay, monitoring of APTT, it is not required. So it is an alternative and preferred anticoagulant over unfractionated heparin. For STEMI, we need to use intravenous or parenteral, I should say, parenteral anticoagulants, okay, other than using oral anticoagulants in acute phase. Oral anticoagulants we can use later on if it's needed, but for acute phase, we need to continue with parenteral anticoagulants, okay, and anticoagulants should be continued until we discharge the patient, okay, that is the guideline. We need to give beta blocker, as I have already said. Beta blocker will improve the oxygen supply demand relationship. It will reduce the pain, so we will use it as soon as we see the patient and diagnose the case. It will help in reducing the infarct size, important. It reduces the chances of arrhythmia because arrhythmia is one of the very common complications of STEMI. So we need to use beta blocker even to reduce the chances of arrhythmias. AC inhibitors, very important drugs. We really need to give AC inhibitor within 24 hours, okay, we see the patient. Okay, all patients with STEMI should be prescribed with AC inhibitors until contraindicated within 24 hours, okay. And the benefit is maximum in case of elderly, anterior wall infarct and reduced left ventricular function. What does it do? It has many good effects, okay, among which one I would say it will prevent cardiac remodeling, okay. Cardiac remodeling, what is cardiac remodeling now? Cardiac remodeling is cardiac remodeling, I should say that there is some changes in the molecular level and which ultimately results in a structural change in size, change in shape, change in geometry and change in left ventricular function, which is not good, okay. So we want to prevent cardiac remodeling, which usually happens after having an infarction. So we need to give AC inhibitors, which are very good drugs to prevent cardiac remodeling. So, not tolerable by the patient, we need to use angiotensin receptor blocker, okay. Others, nitrates, definitely we need to use nitrates. It will reduce the preload as it is a vasodilator and it also helps in dilating the coronary artery. So this is all about the reperfusion, that is PCI, fibrinolysis and other medical measurements. One thing I would just like to say, you need to take care that you can limit the infarct size. So for the limitation of infarct size, we need to give urgent reperfusion, okay, urgent reperfusion. Even beta blockers also can reduce the infarct size, beta blockers. And there are some drugs which we should not be using in a patient of MI that we need to know. Steroids, okay, glucocorticoids and non-steroidal anti-inflammatory drugs, except aspirin, of course, except aspirin. Should not be used, should never be used in a patient of suspected myocardial infarction because they do increase the infarct size. So, very important to know this, steroids and NSAIDs except aspirin should not be used in a patient of suspected myocardial infarction. Complications. So what are the complications a patient may develop? There are various complications, life-threatening complications, okay, which the patient may develop. Patient may develop hypovolemia, cardiogenic shock. Patient may develop life-threatening arrhythmias, okay. Other than that, patient may have recurrent myocardial infarction resulting in recurrent chest pain. There may be complications like pericardial effusion and pericarditis. There may be thromboembolism. There may be left ventricular aneurysm. I was talking about cardiac remodeling. Cardiac remodeling may ultimately lead to left ventricular aneurysm, reduced left ventricular function, okay, left ventricular arrhythmias. So many things cardiac remodeling can lead to, which can be prevented by using a drug which is ACE inhibitors, again which is important from your MCQ point of view as well. So this is about the complication. You may be asked what are the complications of myocardial infarction and how do you manage it. I am not going to go into the detail of the management of these things because I will discuss the management of this in other classes as well. So just know these are the complications which a patient of STEMI may have post infarction, and we need to really search for this complication, we need to manage. Post-infarct risk stratification. This is nothing but prognosis. How do you prognosticate a patient? Okay. It basically depends on three factors. The most important factor is resting left ventricular function. If left ventricular function is good, resting LV function, then the prognosis is good. And residual, potentially ischemic myocardium, okay, which is not been salvaged, and susceptibility to serious ventricular arrhythmias. Many of the patients, they do lose their life because of deadly ventricular arrhythmias. So these are the prognostic factors: resting LV function, potentially residual ischemic myocardium, and susceptibility to ventricular arrhythmias. If you need to see for these factors if you want to prognosticate a patient. So after a patient has a myocardial infarction, that is STEMI, and we have managed a patient, okay, in acute stage we don't need to run after investigations. We really need to manage the patients, and later on, once the patient is managed, patient is stable, we can do other investigations. We can find out how much is the left ventricular ejection fraction by doing an echo. We can do cardiac perfusion scan, we can do MRI, we can do scintigraphy like PET scan. Everything can be performed safely in a post-infarct patient, and we can do Holter monitoring also to find out if there is any arrhythmias going on. Okay, so these are the investigations we can do after we really stabilize the patient and we do reperfusion therapy and all. Lastly, secondary prevention, very important. Okay, if we don't do secondary prevention and we just treat the present episode, again the patient will present with recurrent myocardial infarction or future, there remains future risk of death. Okay, so lifestyle modification is one thing very important. The patient should be physically active. Okay, patient should do exercise under training up to a tolerable limit. Okay, there are different protocols for exercise also. I am not going to go into the detail. And patient should have a dietary modification as well. Patient should be restricted on salt intake and other dietary modifications. Details I will not go. Modification of lipid profile, which is very important. Dyslipidemia is one of the very important risk factor for again developing CAD. Okay, so dyslipidemia should be treated with the help of statins. Patient of myocardial infarction, what we do, we usually give high dose of statin. Okay, we can, for example, we can give atorvastatin of 80 milligrams. Okay. Along with the aspirin, we usually give along with the antiplatelet, that is aspirin and clopidogrel, we do prescribe atorvastatin 80 milligram also because it helps in plaque stabilization. Okay, and it has so many other good effects. So statin should also be prescribed, and in the long term also statin should be given to control the dyslipidemia or to have a good lipid profile. Antiplatelet should be continued indefinitely, as I said. Inhibition of renin-angiotensin-aldosterone system, that is either you use ACE inhibitors or ARBs for long term, beta blockers for long term, nitrates for long term, anticoagulants for long term, and you may use some literature will say about the use of antioxidants like omega-3 fatty acids. These can also be used. So this is all about the secondary prevention, which is really, really important. We need to continue these drugs, as I have said, for the long-term management. We need to follow up the patient. Okay, look for the compliance and look for any other complication the patient is developing or not. Thank you so much for your patient hearing. Okay, really thank you. You had to bear with me today so many times. There were so disturbances and we could not start on time also. I do apologize again for that. Thank you so much once again. If you have any queries, you can just let me know. I'm here to answer your queries. Any queries, please let me know. Okay. Uh, Dr. Naeem, you have asked if a patient comes with anterior wall myocardial infarction with clipped class 4 after 1 hour, what should be the management plan? Definitely, we need to go for a PCI. Okay, we need to do angiography of the coronary arteries and we need to do either stenting we can do or CABG. Okay, it will definitely depend on the patient's disease status. If there is a single vessel involvement, you will do a PCI. If there is multiple vessel involvement or the left main vessel is involved, you're going to do a CABG. In this case, we do not prefer fibrinolysis. I have already said clip class more than 3, that is patient will come in cardiogenic shock, we need to do a PCI. That is the management. In spite of so much of technical issues today, I really got good response from you. Thank you so much for attending the class. When you attend the class, it really encourages us. We really feel like teaching, when you encourage us like this. Thank you so much. Someone has asked about my qualification. Okay, so I'm a consultant physician. I'm an MD medicine, MD general medicine, and I'm practicing medicine. And I'm an assistant professor in one of the private medical colleges in my state. Thank you for asking that. Thank you so much for appreciating my lecture. Minusri, please give class on ECG. Definitely, if I get a chance, I will take classes on ECG as well. Ira Rani, kindly give classes on ECG, definitely. Ira, I will try to do classes on ECG if I get chance. Thank you so much. I think there are no more queries for now. You have any queries, please go to the class again. If you have any queries, you can really ask me. You can ask me in the comment section. I'm always there to reply. Thank you so much. Once again, thank you so much for attending. Let's have a good night's sleep now.